gosh almighty, what he's got to say, we need to hear. So, it took about 4 months to set it all up. His credentials are on the back of the sheet you've got. And I'll turn it over to him. Stop for coming.
No problem. That's my pleasure. Probably you ask yourself why I'm here. Most of you see, sleep apnea, big thing. Let's hear more about this thing. What sleep apnea is. My specialty is not sleep apnea. I started as a cardiopulmonary rehabilitation person. So I did my master, my PhD, so 6-7 years, just how to treat patients that have cardiovascular and respiratory problems. But then, by doing that, I saw a small amount of patients, particular patients, specific patients, that were complaining about this sleep apnea. So in 2005, 2006, that was not a big understanding at that time what sleep apnea is and who's affected. That's why if you look in the literature, if you look and you ask people how many sleep apnea patients are out there, they will tell you, I don't know, the prevalence probably is 2 to 5%, a little bit higher, 10%, because not everybody is diagnosed. Not everybody knows they need to get diagnosed. So I shifted my interest from cardiac rehabilitation, pulmonary rehabilitation, and all of you probably went through this cardiac rehabilitation or pulmonary rehabilitation. Pretty much the same. You go on those treadmills, you exercise a little bit, do some arm ergometry, some weights. There's nothing new for you, correct?
Yeah.
But I wanted to make sure that I can teach those patients, that I can help those patients that have, in addition, a sleep apnea disorder. So that's where I started shifting towards sleep apnea. And mostly, I'm a professor. I come from Rockford University, down in Roanoke, Virginia, and the department I work for is physical therapy. So a lot of physical therapists, we teach students to become physical therapists. And some of their classes they take in their whole cardiopulmonary classes, so that's what I teach. But my research is sleep apnea. So I can do my research, I can get some of those students, these are graduate students, and I can ask them to do research like the one that I'm going to talk about. So I'm a professor, I work with a lot of sleep physicians, because otherwise it's hard for me to have access to the patients that have sleep apnea, and if I want to test them or get some information from them, I don't have access. You have to be a physician, you have to see those patients all the time. So we have a good collaboration with a lot of local physicians out there, sleep physicians. So you can see the relationship. Sleep apnea, and most of you that have sleep apnea went to get diagnosis or went to get screening. Probably it's called a sleep clinic or sleep from a sleep physician, but those are pulmonary specialists. So sleep apnea is kind of a pulmonary issue as well. So everybody, all those physicians are trained as pulmonologists. So you can see the relationship, and from the discussion today, from the presentation, you'll see how close they are related. Pulmonary issues, sleep apnea, and then all the other consequences. I will show you a little bit. I don't want to scare you. I don't want to show you, look, sleep apnea is so bad, all these things can happen. But I want to educate. I want to make sure that, let's say, not you, but your friends, your family, somebody else would use that information and prevent a lot of the consequences that could that you or somebody else can experience. So I hope you can ask a lot of questions at the end, and I'll try to answer to the best of my abilities, because like I said, I don't know a lot of, every little thing about, if you ask me about treatment or who can prescribe or what's the best treatment, I'll give you my best answer, but probably you might need to go back to your physician. But at least if I can make you do that, or you make somebody else do that, go to your physician, the sleep physician. Because that's the first thing that it's missing. A lot of people go undiagnosed. They've been going for years, 10, 15, 20, 30, 40 years, and they discover, oh, I have hypertension, I'm taking medication, 1, 2, 3, 4, 5 pills. Blood pressure doesn't go down, it's still up. Or, oh, I'm developing diabetes. Nothing works. I'm taking medication, but nothing works. But they forget they might have something in addition. They might have sleep apnea that can exacerbate all of those. That's why your hypertension does not respond to the treatment. It is not me saying that. All of these words or all these facts that I'm going to present are based on research, based on trials, based on following patients, hundreds, thousands of patients for years. Oh, you taking medication? Like hypertension, I'm going with that. Oh, year, 2, 3, 5, 10 years. Why you don't respond? Oh, let's do a sleep study. Oh, you have sleep apnea. Let me treat you. 2 weeks later, blood pressure goes down 10 millimeters from, let's say, 150, 140. Let's go 6 months, 130. Without no other changes. No increase in medication. No increase in dosage. No, just I'm adding a treatment. So I'll start talking a little bit. I'll present all this. I dim the lights, so I hope you will see what I have here for you guys. I always believe that helps when you can hear things coming from somebody, from a radio, from a live person, but also you can see it. And then probably later on we can go discussion like not one-on-one, like a specific question and answer, and somebody else can understand that information as well. So the title is The Unknown Danger Everyone Should Feel. Why did I say unknown? Like I said, it is grossly, vastly, widely undiagnosed. And you'll see later on I'm going to specify some things. Who goes for a diagnosis? Why do you go to the sleep physician to get diagnosed? Oh, do I have sleep apnea? Why do you go? Who can tell me? Because some of you already had been tested. Why did you go?
Because personally, I quit breathing so many times during the night.
Okay, that's one clinical feature. People stop breathing during the night. But that's one that has been witnessed. So somebody told you that you stopped breathing. You wouldn't know.
Doctor tells you go get tested.
Okay. One of the
For me, I was in the cardiac unit upstairs,
yes.
and they noticed it.
Yes, they noticed. So somebody else noticed it, or you have some additional comorbidities that the physician know. If you have this, you most likely might have some sleep apnea. But the primary reason people are going for sleep apnea is sleepiness. It's being tired during the day. So if you go to your primary physician, you'll fill out questions. Hey, how you feel? How's this? Are you sleeping during the day? Are you tired? And you say yes. The physician will start saying, okay, that's one point that I need to keep in mind. You are tired. But now you tell me, who's not tired during the day? Who is not? Everybody. So for me, being tired or being fatigued or being sleepy during the day does not help me as much. So that's why a lot of people, oh, I'm tired, so what? Doesn't mean I have sleep apnea. It might be true. But because of that, not a lot of people are going for the screening, for the diagnosis. Because for sure, yeah, I'm tired, so what? So it's vastly unknown. It used to be, and somebody already alluded a little bit, about the awkwardness of the test. In order to be diagnosed, you have to go to the hospital. Go to the clinic, sleep overnight, get all these wires. I'll show you a little bit. Yes, difficult. Yes, cost money. Yes. there are long lines for those beds to be available. If you go right now, probably they'll have a room for you in, how was your experience? In how many
4
days?
days.
How many?
4.
In 4 days?
Yeah, but they told me if I'd gone through ECU, it would take 6 months.
Okay. So that's, I did not go extreme to 6 months, but sometimes you have to wait at least a couple of weeks. And imagine you, I'm just telling somebody, again, I'm using a extreme example, you have cancer now, but let's wait 2 months until you will get treatment. Okay? We can do that. Let me screen you now and find out you have it, let me treat you. So this difficulty in screening could also lead to the disease being unknown. Now, I will just give you a little bit of reference about sleep. You know, healthy people, so everybody, when they sleep, why do they sleep? A third of our life we sleep, we spend in bed. Okay. Do we need to do that? I'd rather spend that third time doing something else, fun. But can I keep doing that? Can I be awake for 24 hours?
Your body's gotta rest.
Body has to rest. And there's different theories for why the human body needs to rest. And one is the respiration theory, which a lot of you could understand it, rejuvenate, repair. There are different processes inside of the body that are enhanced during night. So just at night, you need to have that sleep because you have all these repairment. So you get ready for the next day. So I'm using that analogy for your cell phone. Can you use your cell phone continuously? At one point, after a day, 2, 3, 5, 10 days, you have to plug it in, charge it in. Okay? It's not going to work. Kind of the same thing happens to you. You have to charge in. You use the night with those 6, 7, 8, 9, 10 hours of sleep. Usually as you age, you have a shorter amount, but you use that time to recover. And then those are kind of inactivity and conservation theory. They're coming from evolution. Like when we compare ourselves with other animals, we needed to conserve our energy because at night, let's say, it was not too much going on. Could I hunt a lot during the night? No, I couldn't. So let me save that energy for during the day so I can use more energy when I can, get some prey. And those are just the theory. So in reality, we need sleep. Okay, everybody needs sleep. What happens during sleep? In everybody, this is what's going to happen. We have a decrease in ventilation. So I don't breathe. I don't inhale, exhale as much when I sleep. In everybody, not just in people with respiratory or cardiovascular or fibromyalgia, anybody will breathe a little bit less. We have an increase in airway resistance, so the air comes in, but it's going to have to fight a lot of obstacles to get in and diffuse through all the organs. Okay, that happens to everybody, and this respiration usually is sustained just by the diaphragm. There are a lot of muscles helping with the respiration, but because at night, the muscle tone usually is limited. You don't use it. Those muscles will not going to help you, the respiratory muscle. So you're relying mostly on the diaphragm. That's for everybody, okay? All of you, without young, old, they all experience this during sleep.